Hello again, and welcome to Optimum Anesthesia, where you will find interesting and enlightening talks on anesthesia. The topic we'll be discussing today is a critical one in pediatric anesthesia: the administration of anesthetics to children who have myopathy. We hope that by the end of today, everyone can grasp the fundamentals of this issue, which has implications for households all around the globe. Myopathy is a spectrum of muscular illnesses that increases the difficulty of administering anesthesia to pediatric patients. In order to help you better grasp this complex issue, we will outline the most important factors in detail. Imagine you're at the helm of a child's anesthesia procedure. The first thing on your checklist? Standard monitors, always. They're like the guardian angels of the operating room, tracking vital signs and keeping an eye on the patient's overall well-being. But what if the surgery is more complex? That's when we pull out the big guns: advanced monitoring tools. Think of them as our special ops team. When the situation calls for it, we can bring in invasive arterial blood pressure measurement, transesophageal echocardiography, and central venous catheterization. They're like our superheroes, ready to handle anything. Now, let's dive into a particularly intriguing aspect of pediatric anesthesia: brain monitoring. For kids with myopathies, we have an extra layer of safety: a processed electroencephalogram (EEG) monitor. It's like our secret agent, guiding us in administering intravenous anesthetics to prevent accidental awareness during general anesthesia. The choice of anesthetic agents is not one size fits all. It's a bit like cooking: you need the right ingredients for the right dish. For children with myopathies, it's even more crucial, and here's why. First, we play the role of detectives, assessing the risks. These young patients are potentially vulnerable to conditions like malignant hyperthermia, MH, anesthesia-induced rhabdomyolysis, AIR, or the propofol infusion-like syndrome. It's like navigating a maze: you've got to be cautious. Now, here's the fun part: the patient-specific anesthetic selection. It's like choosing the perfect outfit for a special occasion. We base our choice on the individual patient's risks, their specific myopathy diagnosis, and their other health factors, particularly their cardiac health. Imagine that children with myopathies have superhero-level sensitivity to anesthetic agents, sedatives, and opioids. It's like they have a special power, but it can be tricky. So, we have to adjust the doses like a skilled musician fine-tuning their instrument to create a beautiful symphony. First up, let's unravel the association between myopathy and malignant hyperthermia, or MHS. The susceptibility to MHS isn't one size fits all. It varies based on the specific myopathy diagnosis and the underlying genetic defect. Now, picture this: anesthesia-induced rhabdomyolysis, AIR. It's a condition where the muscles break down and release myoglobin, which can be life-threatening. AIR typically strikes patients with muscle diseases like Duchenne muscular dystrophy, DMD, and Becker muscular dystrophy, BMD. So, what's the recipe for a successful anesthesia procedure? The choice of anesthetic agents is crucial. Imagine it like cooking: you need just the right ingredients. For children with myopathy, we need to reduce the doses and be extra cautious. There are also certain anesthetic agents that are off the menu for these kids. Succinylcholine, for instance, is a no-go due to its risk of causing acute rhabdomyolysis and hyperkalemia. And halogenated anesthetics should be avoided, especially for the induction of anesthesia. Let's talk about propofol. This anesthetic is widely used, but it can be tricky for children with mitochondrial disorders. High doses may lead to something known as propofol infusion syndrome, PRI. It's like a delicate balance: too much, and you risk a metabolic disaster. This brings us to the point, it's often better to err on the side of caution and avoid propofol for total 4 anesthesia or prolonged sedation in children with mitochondrial diseases. Now, let's discuss airway management, a crucial part of pediatric anesthesia. When it comes to neuromuscular blockers, succinylcholine is off the table due to its risk of life-threatening hyperkalemia. So, what's the alternative? It's all about precision, carefully considering non-depolarizing neuromuscular blockers while keeping a close eye on muscle mass and acetylcholine receptors. Moving on to pain management. We're looking at a multi-step strategy, like pieces of a puzzle. It could include non-opioid analgesics, regional anesthesia, or techniques to reduce the need for opioids. When it comes to positioning during surgery, think of it as an art form. Careful placement to avoid pressure points and injuries is crucial. And remember, patients with myopathy are more susceptible to hypothermia. We use active warming and monitoring to keep them cozy. Wrapping it up, post-surgery is a critical phase. For some children, especially those with respiratory issues, extubation might be delayed. It's like playing it safe to ensure a smoother post-op journey. Simply put, giving anesthesia to children with myopathy requires a fine balance between clinical expertise and empathy. Their safety and well-being is paramount, therefore we'll be taking extra precautions whenever possible. I appreciate your time and interest in the topic of optimal anesthesia with us today. With any luck, this episode has clarified some of the murkier aspects of anesthetic care for children with myopathy. Please pass this information on to anybody who could benefit from it if you find it useful. We are here to guide you through the maze of healthcare terminology and procedures. Please get in touch with us if you have any inquiries or suggestions for future content. Keep an eye out for future episodes full with useful information. As the saying goes, knowledge is power. We are now signing off till next time. Stay well and safe.